Welcome back to Bendy and Strong. This is episode 10, and this podcast is all about strength training with hypermobility and Ehlers-Danlos syndrome. So this is for you if you are currently strength training and you just want some extra tips, or if you want to start strength training, or it's also for strength coaches or rehab specialists who are looking after people with EDS or hypermobility and want to know how to work with them a little bit better. So today we've got Shant on the show again. He is my rehab specialist. I've been working with him for a number of years now, and he looks after all of my EDS problems and a lot of my EDS friends and clients because I don't trust many people, and Shant is one of them. And through this, he's actually become quite an expert on hypermobility and Ehlers-Danlos through working with them. He and I discuss this stuff all the time. So it's really awesome to have him on. And today we're going to be talking about something that is inspired by a TikTok video I did recently. And this TikTok video, I was talking about how there are these seemingly safe or benign exercises that can be extremely triggering for people with EDS. And when I say EDS, just to clarify, if you're someone with hypermobility who is in a lot of pain because of your hypermobility, or you're getting dislocations, or you consider yourself probably a bit more on the severe side of hypermobility, I'm including you under that banner. So I'm going to say that word a lot, but that's just to clarify what I mean there. I don't see too much difference when it comes to the joints in treating people with hypermobility or EDS. Like, I think it's something that we can kind of collect together. So coming back to what we're talking about today, which is these seemingly benign or safe exercises that everyone thinks are accessible, but people with EDS can have really bad problems with. And the reason why I think this is important to discuss is, firstly, just from an education standpoint, we know to avoid these, we know what we can do to help with them as well. But secondly, from a mental standpoint, if you have EDS hypermobility, and the first one we're going to talk about is walking. If you're struggling to walk, everyone thinks of walking as just the lowest load exercise of them all, the safest exercise of them all. And it only goes up from there. And if you're here thinking, oh my goodness, I can't even do the safest exercise of them all, how can I even imagine doing these more advanced exercises? I'm screwed. That's a really bad place to be mentally. So I think talking about this, I'm a high level athlete and I can't walk sometimes, and that's okay. That's explainable when you understand EDS and my specific injuries or pains that I've got with my EDS. So I want to talk about this because I think it's important for us with EDS and hypermobility to understand. It's important for clinicians to understand. It's important for coaches to understand. And I think it can also be a bit of a fun topic to talk about because it's kind of funny to talk about how I can deadlift. Well, I could at one point deadlift well over 200, but walking was a bit of a struggle for me. So without further ado, let's get stuck into it. As I said, walking is the first one. And I think walking is also really tricky because it is a free form of exercise. And this is something I talk about quite often. People with EDS and hypermobility are at a big disadvantage because everyone needs to access exercise. Exercise is one of the best things that humans can do. But a lot of the free forms of exercise are really inaccessible for us. Yeah. So walking, let's talk about it. Shant, what's your experience as a rehab specialist, especially with hypermobility and Ehlers-Danlos with walking? Is it as low load as people think? Is it as safe as people think?
Look, in many cases, walking can be a very, very challenging exercise because of the accumulation of forces. Now, what I mean by that, let's take one step back. Let's talk about EDS and hypermobility and why walking can be a risk factor.
Mm-hmm.
And when I say risk factor, I'm talking about at a very specific point in time. I'm not talking about in general. If you have EDS, if you have hypermobility, you should not walk. That's not what I mean.
Yes, just to butt in here, one of my big principles with EDS and hypermobility is do not let your diagnosis become your prognosis. So prognosis, for those who don't know, is like the estimated or predicted outcomes, future outcomes. So don't let the fact that you have EDS and you see that someone else with EDS can't do something, don't let that get to you and think, oh my goodness, I'm never going to be able to do these things.
Yeah.
So if you can do these things, great, good on you. Keep doing them. Keep it in your mind. Maybe at some point they might be a bit cause some problems, but yeah, we don't want to get this. This is not a doomsday talk. This is for
No.
people who are currently experiencing these problems.
Yeah. It's all about understanding and become knowledgeable about the challenges that we face. So, walking, EDS, and hypermobility. When it comes to EDS and hypermobility, you have a little bit more laxity within the joint because the connective tissue that's holding everything together, they are a little bit more lax compared to non-hypermobile or non-EDS population. So what's happening here, think about this is a joint, right? So these two bones coming together, creating a joint. In a non-hypermobile or non-EDS population, the joint has this much movement. EDS and hypermobile population may end up having this much movement.
For those who are listening, there's a lot more movement with the hypermobile people.
Yeah. So now we have gone from this much to this much movement. So the stability is significantly compromised. Now, as simple as walking may seem, think about how many joints are involved in that tasks. And it's also a contra movement and unilateral task. What I mean by that, one leg is doing one thing in one direction, the other leg is doing exactly the opposite thing in the opposite direction. That's how we move forward. So we have a little bit of an instability, sometimes a lot of instability, lack of joint stiffness, and we have this excessive range of motion producing force in opposite direction repeatedly over and over again. So that creates a challenge for the hypermobile and EDS population. Now, we have good days and we have bad days. When we have bad days, what happens is those repetitive movements or repetitive, let's call it a little bit of a micro challenges, add up and can become a big problem or a big challenge for us. So what's happening here is your right leg is going backwards and your left leg going forward, but your hip is not as stable as we want it to be because there's a bit of a movement in there.
Yeah, because I would say just to give information for anyone without EDS or hypermobility who's listening, probably the main problem joint for people with EDS and hypermobility with walking is the hips and the sacroiliac joint, correct?
Hips and the sacroiliac joint. The reason...
Other joints can be a problem, especially if people have existing problems,
Yeah.
but this seems to be the more universal issue.
Correct. So when it comes to walking and running, almost 50% of our power actually comes from the hips. So a significant amount of power is being produced at the hips. So that's why that is at the higher in the food chain of presenting with problems. So we have all these extensor muscles in our hip. Extensor means the ones that is producing force to the back. So they're producing force to the back so you can move forward.
Yeah.
Right? So think about a jet engine. The jet engine is producing force to the back, so the plane is moving forward. So the muscles in the back producing force in that direction, so you can go this direction. All those muscles, they attach in that hip and that sacroiliac joint region. That's where they originate and insert. So one end of the muscle that originates in that area and the other end would attach around the hip area. If you add the force of all those muscles together, you can lift a small car with that force. That's how much force you're producing in that area. Now add a little bit of instability to it, a little bit of an imbalance to it. Repeat that multiple times. That can add up, and become a big problem. And that's why something as simple as walking can feel like is such a daunting task. It feels like it's an impossible task at times. It feels like, oh my God, I can't even go like 5 steps without my sacroiliac joint being in pain, like someone's putting a knife through my back.
Is that made worse by the fact that the there's the one leg forward, one leg back, so there's the twisting through the pelvis, or is that more with other exercises like lunges or something like that?
So lunges is just another variation of walking type of movement. It's a unilateral movement. Uni means one, so one-sided movement. So one leg at a time, as opposed to squat where you're moving with both legs at the same time in the same direction.
Yeah.
So lunge is just a little bit more challenging version of walking. There's a bit more load. There's an increased range of motion being challenged as well. So you're adding a little bit a few more stresses to that walking type of movement. So things are getting a little bit more challenged, and if you can't meet the challenge or match the force profile, then again the same thing, lack of instability, a little bit more weakness here and there, a bit of a dysfunction, and it's going to create a bigger problem for us. And generally, like I said, majority of the power is coming from the hips. Most of the muscles are attaching in that area. So that area, the SIJ and the hips tend to be the area where you get most of the pain and discomfort.
Yeah. So for those following at home, lunges were the second exercise on our list that we were going to be talking about. And I think in terms of like, just to give like, if we can give in 1 minute some tips for this, with the walking, some things that I've found have helped is I use a sacroiliac joint belt, which is one of the ones that have been designed for pregnancy, but I'm not pregnant. I still use it. When I'm walking, I do my activation exercises, which Shunt has devised for me before I do any kind of walking. And the other one that we worked on for my bodybuilding prep when I was doing walking as my main form of cardio, and I had terrible SIJ problems, was we kind of almost regressed the walking. And the only way to regress walking is to do a shorter period of walking.
Yeah.
So we found, let's say at 20 minutes, that's when I had my capacity, or 15 minutes was my capacity. That's when I started to hurt. So I took it back to 7 minutes, something underneath my capacity. So with EDS and hypermobility, there's always a capacity. Sometimes it might be 1, but we need to find a way to find out when, not just does this exercise hurt me, but at what point does this exercise hurt me? And then can we work 5 steps backwards from there?
Yeah.
And improve that. And then over time, our capacity improves. Do you have anything to add to that?
Yeah, so I think this is where your clinician comes in very, very useful as well. So if you have a clinician who understands EDS, hypermobility, and strength training.
And if you don't, Shant is your guy.
So this is where a clinician can precisely assess, okay, where is the problem happening and what do we need to strengthen? So if you can strengthen things to stabilize things, so we can do things a little bit better, maybe for a little bit longer. So while we were doing the activations for you to create the stability, we could walk for 10 minutes. So, okay, we regress back to 8 minutes or 7 minutes. And we did that multiple times throughout the day. And then we nudged it a little bit because we knew that with the activations, things were starting to feel a bit better. So now we can progress things a little bit more. Until we got to a point, okay, now we can do 15-minute walks. Now let's put 2 15-minute walk close to each other. We go for a 15-minute walk, and within the next hour, you're going to go for another 15-minute walk. So that means now we're getting close to a 30-minute segment of walk. So now we're going to bring those two close together until we know, okay, now we can go for a 30-minute walk. It feels like daunting, but before you know it, within a few weeks, you're back to walking. The thing is, you need to remember, if you can walk for 10 minutes, that you're 10 minutes ahead. See the positive. I know it doesn't feel like sometimes, but if you can do 10 minutes, that means you are 10 minutes ahead. And let's start with that. And then let's start building on top of that.
Yeah, I think actually one other thing I would add onto this is understand some of the external triggers with walking. So for sometimes it's walking on a slope. Sometimes it's walking on uneven ground. For me, a big trigger is when I walk my dog. He's very strong. If he pulls at something, that's then creating extra twisting because my torso is twisting. So I tie his leash around my waist just so that it's not doing that. So understand those external triggers that can make walking more difficult. Again, if we don't see the patterns, we feel like everything is bleak because everything hurts. But there's usually a pattern, and if we can find those patterns and work around it, that's a good way to do it.
Absolutely.
So with lunges, any tips? I think probably my main tip that I give as a universal thing is be wary of the menstrual cycle. If you're someone who gets a menstrual cycle, if you're training someone who has a menstrual cycle, be wary of that at certain times. And I think it will sometimes vary from person to person, either slightly before or during menstruation, there's extra laxity in the joints. And I would say, if you're having a flare up, if you know that your hips get flared up or you've got problems in this area, when it's bad, just there's no need to do lunges. There's other exercises that you can do. And then from a proactive perspective, training around the menstrual cycle, just being wary of that when the joint laxity. I'm not a big fan of, adapting all of your training around your menstrual cycle and intensities and all that stuff. I'm not huge on that, but this one thing I am really big on.
Absolutely.
And that is knowing that my joints are more lax, either before or during my period, and just being proactive about it. So I don't think, oh, damn it, that's the thing. That's why I hurt myself, was because I didn't do that.
Yeah. I think that's very, very important to remember. And I found this to be a very useful tip within the Ehlers-Danlos and hypermobile population. During the menstrual cycle, either minimize or manage your unilateral exercises such as split squat, lunges, a lot of walking, a little bit less. And if it's really hurting, don't do them. And focus more on bilateral exercises, meaning two-legged exercises such as squatting or hip thrust or deadlifting, whatever works for you, whatever the safer option for you. Focus on those things, and you can always come back to those.
Yeah. I would add on that as well is that for some, with some coaches, if you're working with a coach, sometimes a coach will just throw in a unilateral exercise because they know that someone's got a weakness somewhere.
Yeah.
And it's almost like a blanket, just let's throw a unilateral exercise at it.
Yeah.
Be really mindful of that. With EDS and hypermobility, we have this tendency, like I always say, if we can do something wrong, we will do it. Our body will find a way to do it wrong. So just be really mindful of this, because if we've got a muscle weakness and we're trying to fix that with lunges, oftentimes that muscle weakness will just shine through with the lunges and cause more problems. Yes. So a regressed version of an exercise, I consider single leg lunge exercises extremely advanced for people with hypermobility, especially under load. And especially, something like a Bulgarian split squat where the back leg is pulled back even further. For me, that just is that's even more advanced. So just be aware that A, you don't have to do these exercises, and B, you don't have to do them all the time, and C, you don't have to go crazy with load. Happy with that?
Happy with that.
All right, let's go to the next one. So this one is a big one for a lot of people with EDS and hypermobility, probably other people as well, is when you're doing ab exercises, especially ab exercises on the floor that involve crunching up, getting really tight through the neck and the jaw and the upper traps.
Yep.
Over to you.
So
I don't have a solution for this. It's still a problem for me. Over to Shan.
So one of the things with those ab exercises, they are not bad exercises. They're just not sometimes the right exercise for the right person. Especially when it comes to EDS and hypermobility, because the population has a little bit of extra laxity. This is not specific to just neck and jaw or ab exercises. The body is always in a state of adapting. It's constantly trying to stabilize or look for strengths to protect joints, because they're a bit of a laxity there. So when you're doing ab exercises lying on your back on the ground and you're lifting your neck up, the head weighs about 10 kilos. So when you're trying to lift them up, if you already have pre-existing laxity there, the brain will perceive, and I'm using the term brain very loosely here, the brain will perceive that as a serious risk. So it will tighten up a lot of the muscle that protects. So it pulls everything together to shorten things to protect that. And that's what we find to be tight, or that's what we find to be uncomfortable. So when you're doing those ab exercises, not only you're contracting your abs, but you're also contracting everything here to protect the head from falling backwards, or to fight against the laxity or the fight against the instability. So one of the things that, in your case, we had to modify certain exercises. You had to do things standing upright.
Like a cable crunch or
so like a standing cable crunch or just a cable hold. Or in some cases, it was a very small hold because the intra-abdominal pressure comes into play as well.
I've even found the big exercise balls, doing it on that, but rotating myself so that my hips are almost on the ground so that I'm actually in a more upright position, so that there's less pressure on my neck. Things like that have been really helpful. And I mean, some people will use the cue press the tongue onto the roof of the mouth, which sometimes helps, but definitely not all the time.
No. Look, it can be a double-edged sword. Like if you're pressing the tongue, and again with EDS and hypermobility, everything is a little bit exacerbated. So if you're pressing the tongue really hard, then you can end up having jaw problem in other direction.
Yeah.
Don't want that either.
No. Do you think it's also like, because people with EDS and hypermobility tend to have tightness here, overactive muscles here anyway. Do you think there would be any benefit in doing like some exercises to prevent that, like some maybe deeper neck stability exercises before doing abdominal exercises?
Look, it kind of depends. So I would say, firstly, we need to establish where the weakness is, because even though a lot of the population getting the neck problem, then they may not all have the problem because of the same reason. So we need to precisely identify, okay, where the problem is coming from. In some cases, it can be that it can be that you haven't really strengthened the other posterior muscles in your back, so you're not really created a very good sound support structure to hold your head in your other everyday activities. So by the time you have gone to the gym to do these exercises, they're already a little bit tired because they've been carrying around the head. So that means we just need to look at the whole picture, what other things that we can strengthen as part of the strength program. But also in terms of the neck, in some cases, a bit of a distraction work, meaning pulling things back, can work. In other cases, lifting the head up from a decline position, so the head is about to fall backwards, and just holding it in neutral can help because it's teaching you the neutral positional awareness. In other cases, some cable neck work can work because we're strengthening the muscle. Again, the right tool for the right person, but you notice one thing that is common, I'm looking at strength as a solution for all the different problems that I have presented.
Yeah, I would just add on to that, the thing that we've talked about before as well is the right solution for the right person at the right time, because the thing, like some of the neck exercises that I've done a couple of years ago, I do them now and I'm like, it's just not working anymore. It's not that the exercise is bad. I've just adapted to it and I need something else.
Exactly. So, and this is the challenge with hypermobility and the EDS crew. It's a set of exercise works really well in the specific direction, and after a while it stops working because, again, your body's in such an adaptive state all the time that if you start to get strong in this direction, you do a really good job at it. Now we're going to start presenting problems on the other direction. So it's almost constantly like you keep updating your exercise protocol.
So this one, the moral is don't be afraid to adapt exercises away from that crunching movement, lying down crunching movement, to either a standing up crunching movement, or we could even consider something like a plank, a side plank, still hitting that area. So it's, I guess, maybe even having a tiny bit of knowledge around anatomy to know how to hit those muscles from a different angle, or utilizing machines and cables so that we can still push against load, but not so that our whole body is moving against gravity.
Exactly. Yes.
So the next exercise we've got here is upright row. This is a common problem one, either feeling it in the traps or getting pain through the front of the shoulders. My approach with upright row over the years has just been, I don't always need to do this exercise. Is it something that everyone should be doing? Is it something that it's pretty okay to say it? If it hurts you, to just avoid it.
Okay. So before we start demonizing upright row, let's look at what is an upright row and what's the purpose of it. So one reason people do upright row, because it's an abduction, it's a shoulder abduction movement, right? So that means this bone is moving away from the body and it's engaging these muscles here. So it's to strengthen those muscles. Is that the only exercise that can do it? No, there are quite a few different exercises. So you can do machine, you can do
lateral
cable,
raise,
all these different variations of lateral raises, even somewhat like front raises as well. There's a whole bunch of things you can do to strengthen that area, and
in a very similar
movement, and for bodybuilding purposes, create definition in those muscles. So upright row is not the be all end all of all exercises.
I feel like it's one that's kind of just thrown into like boot camps and things like that.
Yes.
And group exercise. I don't know. I feel like that's kind of, in terms of when I've done upright rows, it's always been a lot of group fitness settings. And because when I program for myself, I often won't do it, or I'll just say to my coach, that one hurts me. Can we not do it?
Look, it can be one of those things where that you work with the coaches that are working with the tools that they have available, and they need to throw in some shoulder abduction exercise, and they're choosing, upright row as an option.
Yeah. So I would say that this one is for the general people watching this who aren't, doing a specific bodybuilding competition or really trying to hone in on the definition in their shoulders, there's a lot of other exercises we could choose.
Yeah.
And if it hurts, just choose the other exercises.
Yeah. Like with EDS and hypermobility, one exercise I found really useful, actually lying face down on an inclined bench and then do side raises. So the bench is taking away the load of your head and your shoulders. So that means you can purely focus on the abduction work from the shoulder.
Yeah, and we can also think, I think with EDS and hypermobility, there's this so much mental effort into what each joint is doing as we're exercising. So that kind of, okay, we don't have to think about anything except for the shoulder and really make sure that's in a nice place.
Yeah.
Yeah. As a bodybuilder, I have used variations of upright row, but what I'll do often is I'll say, okay, the standard one of using a barbell, doing an upright row, sometimes that puts things in weird positions. It even hurts my wrists sometimes. So I might do a single arm cable upright row at a particular angle that I feel. I'll just play around until I find the angle that doesn't hurt, because sometimes some of the other exercises don't feel good for me, and that's the option that I've got that does actually feel okay. So, but as a general rule for most people with EDS and hypermobility training, I would say there's other exercises to do. And if you're in a group fitness setting or whatever and people want you to do it, just say, can I do another exercise?
Correct. And the other thing you got to remember when you're doing upright row, so different exercises have different strength profiles for different muscle groups. So when you're doing something like an upright row, it engages the upper traps a lot more than a unilateral, like a lateral raise type of movement. So you're engaging a muscle that tends to be very tight with EDS and hypermobile crew anyway.
Yeah. Cool. So the next one we got on the list is Romanian Deadlift, not feeling the stretch at the bottom of the Romanian Deadlift. Now, is this something people with EDS and hypermobility need to feel? I think this is just such a thing. Like people with EDS and hypermobility watching this, you'll be like, oh yeah, I've been to the gym and someone told me to go until I feel the stretch on a Romanian deadlift and I couldn't feel the stretch. I actually have this video of me coaching a friend with EDS. And I gave her a series of cues and I actually got her to feel tension in her hamstrings for the first time ever.
Right.
And it was a very specific set of cues. And, but I know for a fact that most coaches aren't teaching those cues. They're just saying, just bend forwards and go until you feel the stretch.
Yeah. So maybe we can discuss a little bit about external versus internal feedback when it comes to not just IDL or feeling hamstrings, but to do with hypermobile and
because it applies to squats. Go all the way down in the squat.
Yeah.
It applies to so many things. On a lat pull down or a row, cable row, letting it go until you feel the stretch at the bottom. Yeah.
And sometimes it's not just the stretch. If I said go as low as you can go comfortably, you'll be able to fold yourself in half.
I'll sit on the floor. Yeah.
Yeah. So that just because you can do that comfortably or perceived comfortably doesn't mean that's what you should do or that's the safest option for you. So back to RDL, Ehlers-Danlos syndrome and hypermobile people tend to have a little bit less proprioceptive feedback, sometimes almost non-existent proprioceptive feedback. What is proprioceptive feedback? Think about bunch of sensors in your joint sending feedback, your physical awareness in space, your body position in space. It's feeling the length, it's measuring the tension in those muscles and the joints. And they're sending that feedback to the brain. That feedback mechanism is sometimes can be a lot diminished. In other cases I've seen, they almost can't feel anything at all. So if you're looking to feel things, meaning internal feedback, and as a coach or as a clinician, if I'm relying on the internal feedback of what you're feeling, more than likely I'm going to take you in a very dangerous range of motion, or I'm going to get you to do an exercise in a very dangerous manner, past its safe range.
Especially new people in the gym, right? Like new people have less of a knowledge of what their body feels like in space, have less knowledge of the exercise itself, have less knowledge of how to overcome load if they're in a dangerous position, and probably also have less ability to advocate for themselves and say, no, that doesn't feel good to their coach. They just think it's pain. Pain is okay because I'm doing exercise. So,
So rather than give them internal feedback, give them external feedback. So first of all, they can do that exercise safely. Good. Nothing wrong with the exercise then. show them how to do the exercise correctly. So one thing that you always, mention about your training, you like to record your exercises, or you've always logged your exercises. So measuring your exercise externally can be a very good tool how you can perform those exercises safely. And as a coach, you get to see where your client or your patient can do those exercises safely as well. So that's a very good external feedback mechanism that we can use instead of relying on the internal feedback, which is probably not the strongest suit.
Yeah, and there's this thing with, with the Romanian deadlift, because this is the exercise we're talking about, but just as an example of, this go until you feel a stretch in the hamstrings cue, which is just sort of the universal cue that people use for it. And there is more to the Romanian deadlift than feeling a stretch in your hamstrings. This is a useful exercise that you can do to teach the hip hinge, to teach how it feels to hold weight in your hands as a regression from the conventional deadlift. So with this exercise, if I've got an EDS client, what I'll say to them is we're just going to do this in a very shortened range. And this is a principle that I use a lot with my EDS clients is I'm going to teach you the shortened range first. But not just teach you, I'm going to get you really strong in that shortened range. So I'll say to someone with Romanian deadlift, with hypermobility, with Romanian deadlift, let's just lower it down until the bar is just around the bottom of your knee and then stand up.
Yeah.
And let's just do that. And then for the next couple of weeks, it might be 8 weeks or more, we work on that range and progressing it, strengthening it, building strength. With that increase in strength comes an increase of awareness of their body, of what it feels like to move load, of how it feels to be in that safe zone.
Yeah.
So that when we do eventually, if we do increase the range, I know that they are able to safely move in that zone. So an extra centimeter or two, once they go into that and start to come out of it, their body is like, yep, I know how to do this. I know what this safe zone feels like. And it's also teaching us what neutral or non-hyperextended range is for our joints. So it's teaching us where that normal range is so that we can learn to be strong in that range. And also, a lot of my clients come to me because they want to get strong, build muscle, or sometimes lose fat. And by overloading and strengthening the area, we don't actually need to go all the way down to the ground to get the hypertrophy strength benefits from that exercise. We can get it by building strength in that shortened range, because what's the alternative? We use the full range and try to build strength there, and the person's doing the exercise wrong and they might get injured.
Yeah.
And it's going to be slow to progress because we're not using an efficient technique. So, yeah.
Yeah.
Cool. So, next one we've got, I think we've got squats on the list, but I feel like that probably one of the biggest problems with hypermobility and squats is going too far down.
Yes.
And if squats hurt you, I'm a competitive powerlifter. I've been powerlifting for a long time and I'm still perfecting my squat, even though I've been squatting since I'm 30 and I've been squatting since I was 13. So if you feel like maybe squats aren't the right exercise for me, maybe you're not doing them properly, not say that's on you, but maybe the instruction that you've had isn't correct, or it hasn't been adapted to your body, or the cues that people are using for you. Upright torso is a big one. People always said I needed a really upright torso. Well, guess what? I've got really long femurs and a very short torso, which means my squat is naturally going to be a little bit more bent over.
Yeah.
And for years, I thought I was doing it wrong and I tried to force myself into this other position and it never felt good. Do you have much to add to that?
So I think when it comes to squat, one thing I think it's important to remember, not just for EDS or hypermobile crew, but also in general, squat can be a very fluid process. So in my case, when I was a lot heavier, my squat was very different to how I am now. Since I've lost a lot of weight, my squat had to change. Even my shoes had to change, because biomechanically, I could not do the things that I wanted to do when I was a lot heavier. So the other feedback would be range. Again, an example that I have given you is go as low as you can comfortably. Well, that's not going to work really well with EDS, because you're just going to be all the way down to the ground and repetitively stress the structure at that end range, which is not safe for you. So you need to work with a professional who really understands your body, understands biomechanic, understands the right form or the right cues that will work with you, and then go with that. Something else I found interestingly is some of the cues that are very useful for non-hypermobile crew can be actually dangerous for hypermobile
That's
crew.
true.
So I think when we were working on your deadlift, one thing I wanted to pay attention to, I just wanted to grab the ground with your feet. I didn't want you to spread the floor.
Or push my knees out.
Push your knees out, because you have this extra range or extra amount of laxity within the joint.
Because pushing my knees out was actually really hurting my hips,
Yeah.
which is usually the cue used to activate the glute muscles and get the hips feeling good.
Correct. Because you have this extra amount of elasticity and laxity within the joint, if you're pushing the knees out hard, you're basically twisting the knee within that joint. And that's why it was hurting. So we wanted to plant you in a very rigid structure and follow that path rather than trying to force something that can work for somebody who's got fairly rigid structure to start with. But in your case, we need to artificially or externally create the rigidity. So we had to change the cues. The point is, find out that the right cues that work for you. Just because the cue exists on the internet or on social media, don't blindly follow it.
The other thing that I would add onto that, just when you were saying depth, as I said, I've been training for a really long time, and you'd think that by now I could feel like, as a powerlifter, you need to know what depth feels like. And I've learnt that. But what I don't know is, I know that I can do squats most of the time without pain, but a lot of the time I'm not even coming to hip crease below the knee. Does this mean this exercise is no good for me? No. It's a great exercise for me, for building muscle, for building strength, for rehabbing my joints. When I added in squats and I got to the point where I could do them really nicely and comfortably, again, not to what people would classify as full depth.
Yeah.
My hips felt the best that they ever have. So it's a great exercise for me, but a lot of the time I can't tell when I'm going into that, let's call it a dangerous depth. I don't like to use the word dangerous, but it's an easy word to use there. The depth where my hips are going to start hurting. So I'll put a box there and I'll just squat down to the box. Even though I'm a very advanced lifter, I still need that feedback, and that's okay. And that's also measurable, because I know that I'm squatting to this exact height, and then maybe over time I can try and lower that box down a little bit.
Yep.
If it doesn't feel good, go back up to the previous height. But it's knowing that there are lots of levers that we can pull. It's not just weight on the bar. It's weight on the bar, what depth you're going to, which cues we're using, how many sets we're doing, how many reps we're doing. There's lots of things we can use there.
Yeah. And like I said, it's a fluid process. So even in your case, sometimes you can squat to a certain depth. In other cases, you couldn't. So we had to work with the depth you could work.
Yeah. Yeah, for sure. All right. Now I've got push-ups and plank together. The reason I put these two together is because I had a lot of comments on my TikTok video saying people had problems with push-up and plank, and a lot of them said their wrists were hurting. I've got a very simple solution for the plank. Do it on your elbows.
Yeah.
But let's talk about push-up, because I think some people said their wrists, some people said their shoulders. For me, push-ups are not a friendly exercise, and I avoid them like the plague. Even when I was benching well over 100 kilos, I wasn't doing push-ups. Like, I think people feel like push-ups are this essential exercise. I don't think that they are.
No, push-up is one of those exercises, because it's been around for so long. It's probably one of the oldest form of exercises.
No equipment. You can do it anywhere. It's free.
Yeah, and it's body weight, so it's safe. So that's the other perception.
That's so wrong.
It's one of those exercises. Oh, you should be able to do push-up, or if you, it's an exercise.
And if you can't, do it from your knees.
Correct. So let's go with the wrist. So the wrist is a very busy joint. You got a whole bunch of all these little bones. Like some bones, you have this ligament running in this direction. So other bones, this tendons coming in this direction. They're all different shaped. So there's so much movement happening within that joint. Now, that's for non-hypermobile people, non-EDS people. Within the hypermobile and EDS community, you're going to have a little bit more laxity within those joints. So that means when you're putting all of your body weight onto your hands, there's going to be a lot more extra movement as you're coming up and down on your wrists. So that means you're going to have a little bit more challenge there, right? And that's where a lot of my clients, they present with wrist pains when they're doing push-ups. One easy solution can be, if you really want to do push-ups, you can put wrist straps on and you can use handles.
The handles, yeah, that's the. It's a bit harder, but the handles I've found when I was doing a lot of
And
push-ups,
if you
that
don't
made my
have
wrists a lot
handles,
better.
use dumbbells. Like you
Yeah.
can just dumbbells on the floor, and then that gives you something to grab onto, so you have a much better grip and much more stability.
Yeah.
Now, when it comes to the shoulder, the difference between bench or bench press and push-up, when you're doing bench press, you're lying on your back. Everything is wedged in between you and the bench, meaning your shoulder blades, your back muscles, your spine, everything is facing the bench or on top of the bench, and you have something to push against to stabilize yourself. Unfortunately, when you're doing push-ups, you are on your hands, your back is completely open. So that means everything's moving around. So there's an increased amount of instability when you're doing push-ups. Here's another interesting fact. So I deal with a lot of athletes that have shoulder dislocation. And one of my marker for progression or strength progression for shoulder dislocation, which is again laxity within the joint, is for them to be able to do push-ups. So that's how challenging this exercise
It's an
can
advanced
be.
exercise.
Right. So that means I would have to do a lot of rehab and strengthening exercise within that joint so they can do push-up. And that's a test that I am progressing.
Mm-hmm.
So just jumping on the floor and start doing push-ups when you have that much stability being challenged, it can create some problem.
Yeah, the only thing I would add onto this is I like push-ups, as we were saying before, it's this exercise that people think that they need to do. I don't think it is, because there's so many other exercises we can use to, the push-up, the idea is that you're using your chest muscles, your front delts, your triceps to extend your elbows. That could be done with bench press.
Yep.
And in particular, it can be done with dumbbell bench press, barbell bench press. And the benefits of those is that with push-ups, because it's the closed chain exercise, which means that, what we're pushing against is the ground. We're not able to freely move our hands or move our arms or elbows in space, which means that we're kind of locked into this path of motion. And that, for people with hypermobility and EDS, is not always a good thing with the upper body, with the shoulder.
Correct.
I find that, with the dumbbell exercise, you're really in charge of where your shoulders and elbows and arms are moving. And it feels a lot better. I don't do push-ups. It's not an exercise that's in my repertoire. If it's one that you love and you really want to do, we can find ways to work around it. But if you're doing it because you think you have to, there are other exercises.
Yeah. Or if you're somebody within the tactical force, military or police, you have to do push-ups. Okay, there are ways you can do that.
For sure. Okay, so the next exercise on the list is one of Shant's favorite forms of exercise, which is yoga. Let me just say my experience with yoga, why I feel like it can be painful for me with Ehlers-Danlos. Number one, because it's usually in a class format and I don't have any control over what I'm doing. And as a general rule, group fitness or classes freak me out a lot because I need to be in control of my body.
Yeah.
And I don't like someone else telling me what to do with my body, especially when they're teaching a class full of 20 people and it's not one-on-one and I can't give feedback. So that's probably my first thing. The second thing is it puts you in weird positions that you're not used to. My body doesn't always know what to do in those positions.
Yeah.
I do think for some people with EDS and hypermobility, yoga can be, might be the right thing at the right time, but it's very much like if you throw stuff at a wall, something will stick.
Yeah.
Also, we need to distinguish between yoga as an exercise and yoga as a more spiritual sort of internal practice, which can be great for people with EDS because calming the nervous system, and a lot of us are neurodivergent. It can be a really great tool. I know a lot of people with neurodivergence who love yoga for that reason. So I guess that's an important thing to distinguish as well.
Yeah. So let's discuss yoga first. So yoga, it started in the subcontinent as a spiritual practice of finding your inner being. It became a fitness thing when it reached the Western countries. So anything can be yoga. Anything that allows you spiritually, anything allows you to find your inner being can be yoga. You can walk your dog and call it yoga. You can stand in the morning and watch the sunrise, can be yoga. So there's no clear definition what yoga should be. Everybody's claiming all these different variations of yoga. It's all made up. And when I say I made up, I'm not saying it in an undermining way. They just came up with their own, let's call it, fitness philosophies. But yoga as a philosophy, it's more for mindfulness. And that's where it can be very, very helpful for people with Ehlers-Danlos syndrome and hypermobility, because sometimes things can be bleak, and something that gives you a peace of mind or gives you a bit of a calm and serenity can be a beautiful thing to practice.
And on that, I guess a key thing there is if the real big benefits of yoga are these internal practices, we can do any level of yoga. Yeah. I had that old client of mine who I mentioned before, Bernard. He was 80 years old and he came to me for strength training, and he taught yoga to military vets.
Yeah.
He also taught yoga in a nursing home. So there were people sitting in the chair doing the yoga who couldn't stand up and perform advanced exercises. So I guess understanding that there's no shame in regressing it if the goal is internal benefits.
Yeah, and like I said, there's no real definition of yoga. So it's not even regression. You're just doing a different variation of yoga. Let's call it that.
So for let's call it, I think it would be remiss of us to say that in the Western world, there's no sort of standardized thing that people can think of, downward dog, all these kind of exercises with yoga. Why might they be hurting people with Ehlers-Danlos or hypermobility?
So one of the common misconceptions that yoga is going to improve your flexibility, because you're going into all these lengthened positions. Now, for some, it might be great. For others, such as Ehlers-Danlos syndrome and hypermobile population, you already have a lot of laxity, a lot of instability, and a lot of compromised movement within all of the joints. So when you're searching for even further flexibility, or you're putting yourself into a very specific position which really challenges the very end range
when
of
we
your
don't
movement.
have the proprioception to say this is safe or this is unsafe or I've gone too far.
Yeah, and we already discussed what proprioception is. So when you are doing those things, you are constantly putting yourself at risk of being injured because, one, extra amount of laxity, extra amount of instability, lack of proprioception, in many cases, inhibited muscle groups, meaning certain muscles are working really, really hard and other muscles are not working as hard
just
as they should.
Just because of how our body is, just because that's just how we are walking around all day.
That's a protective mechanism.
I would add to that onto that as well, like what we're talking about with push-ups, it being a closed chain exercise, when I think of yoga movements, a lot of them are similar to that.
Yeah.
And that's another thing is I love weights training because we're very much in control of the angle that we're working at, how our body is moving, how much reps we're doing. And I just feel like yoga doesn't quite give you that same thing. All right, next exercise, we've got swimming. Now, I want to preface this by saying for some people with EDS and hypermobility, swimming is the best exercise that we can do. I know some people love it, especially neurodivergent people who love that feeling of just immersing in the pool and just going. I reckon 50% of the people who I talk to with EDS say swimming is their number one go-to. And then it seems like there's this other proportion of people who say it hurts me.
Yeah.
It's an injury waiting to happen. In my own experience, all through high school, I had shoulder tendonitis. And that's a word that we've talked about in a recent video, but that was what it was diagnosed at the time. And stay tuned for that video. But I had a lot of problems with swimming because it triggered that. And so I just had to sit out of all my swimming classes. So what are your thoughts on this?
So swimming is one of those things where, the phrase, the right exercise for the right person at the right time, is very much applicable. So one of the challenges of swimming, it's a buoyant exercise. Buoyant means you're floating on water, meaning you don't have the challenge of gravity. So gravity is very important for proprioception. So when you're standing on ground or when you're bending forward, picking things up in a gym, gravity is what's challenging you downwards and you're resisting against that force. So with EDS and hypermobile population, proprioception is a little bit less, in some cases completely diminished. So for those who feel really good, their proprioception is not being challenged because it doesn't feel like gravity. So the buoyancy actually makes you feel good. In other cases, when we need to challenge proprioception, so we know how to create the right strength profile, lack of gravity, it's not giving us that feedback. So we are going to whatever we have available. In some cases, some muscles that we are already overusing, and we're just going to keep going to that, and we're going to end up hurting ourselves.
Yeah, that makes sense. Like when I think of my experiences swimming, that reflects that completely.
Yeah.
Yeah, cool. All right, last one that we've got on the list is in on this TikTok video, a lot of people commented and said clamshells. That is a very specific reason why that one hurts, but I think we can just extend this out really quickly to some other rehab, just some rehab exercises hurt. So let's go clamshells first.
So first of all, how do we perform clamshells? One of the most common way we perform clamshells, it's bending both of your knees and bending both of your hips, lying on your side in 90-90 position, and then you open the legs up. The aim is to engage the glute muscle into abduction and external rotation, which is this movement, right? And this is external rotation. So what happens is when you're having your knees and hips bent, one of the hip flexor muscles, psoas, also does external rotation in flexion, meaning when you have your hips bent and you're trying to open up the hips, you're actually utilizing the tight muscle that you're trying to get away from. So how you perform clam can be very, very important in what you're trying to engage.
Can it make it come through the TFL at the front of the hip as well, the other hip flexor?
It depends on where you're positioning. So if you're leaning forward a little bit, then it can start engaging the TFL.
Yeah.
Now, Andrew Locke, he came up with the lock clamps, which is a lot safer version of the clamps, where you reduce the flexion or bend at the hips and knees, and you face downwards, meaning you have to put your glutes up against gravity. We just spoke about gravity. So now the gravity is challenging the weight of your leg and your glutes. So you have to kind of engage your glutes.
Yeah.
Given engaging your glutes is the right protocol at that time.
Yeah. And with the lock clam as well, you've got the bottom leg out straight. So
correct.
Disregarding the top leg, your whole body is in a straight line, and then your top leg is sort of bent and hooked over, and then you roll over.
Yes.
Yeah. 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 That's a much better exercise. Whenever I see people doing clamshells the standard way, I used to do them as well, and I just always thought this is a dumb exercise. It's just not working the right spot. So in general, I think that thing that you said at the end, given that this is the right exercise for the right person at the right time, that can also explain why some other rehab exercises, which are seemingly very low load, might hurt. And we've talked about this before, but this idea of, a rehab exercise with people with EDS and hypermobility, I remember at one point hip abductions, so pulling my leg away from my body against, with a booty band and lifting my leg out to the side. That was the solution for my hip. Then fast forward a couple of months, I got so strong at that, it actually became
an aggravator of your injury.
An aggravator, because that muscle became the really active muscle around the hip.
Yeah.
So I think that's another thing is, it's a seemingly very low load exercise. And for most people, they would never even think of that exercise triggering pain.
Yeah.
But with EDS and hypermobility, we have these sort of exacerbated imbalances and extremely strong or active muscles, and then very, very weak and underactive muscles. And if the rehab exercise, which is very light and low load, just happens to be working one of those active muscles, it can trigger and not just trigger the injury, but also can make us think, oh, that's that muscle that I'm so used to hurting.
Yeah.
And oh, that's a trigger for me. My brain saying that's a very sore movement to do.
Yeah. And I think keeping up with the theme, when it comes to EDS and hypermobility, there is no one fix forever. It's a constant updating of exercises, because your body is always in a state of being adaptive. It's constantly looking for solutions in multiple directions, because the increase in stability, the increased laxity, the extensive range of motion within the joints, they're constantly challenging you. So we need the upkeep of your activation or upkeep of your corrective exercises, sometimes upkeep of your strength training can be really, really good. So one example was sometimes you could do sumo deadlift really well. Sometimes you could do conventional deadlift really well.
And then sometimes, like when I was doing sumo, it was because conventional started to hurt me. And then after a while, sumo starts to hurt. So I switch back to conventional. So, and when that happens, I'm not saying, oh my gosh, the injury's back. I'm back to being injured. It's just almost like cyclic. It kind of goes in,
it's a very fluid
phasic.
process.
Yeah. Awesome. Well, that's everything that we had on our list. There's probably some that you are thinking of as you're listening to this. Oh, this really easy exercise gets me. But hopefully just even hearing us talking about this and explaining it helps you to feel like, there's nothing wrong with me if I'm doing this easy exercise that everyone else does and it's hurting me or I don't feel comfortable with it. As I said earlier, consider myself quite an advanced strength athlete, and oftentimes there are exercises in the gym that other people do that I'm like, that's easy for you, but I just can't do it. So I hope that this has helped. And I hope you've got something from it. If you want to follow Shant, he is strength.revolution on Instagram.
Yep.
If you're following me, Annie Short Strength, I tag him in a bunch of my stuff. So you can find him that way or just look him up. Anything else you wanted to add?
No, I think one thing we can summarize from this one is right exercise for the right person at the right time.
Yeah, and don't be ashamed or feel like there's anything wrong with you if it just happens to be the wrong exercise that you're doing and it's not feeling any good. Awesome. Well, thank you so much for your time, Shant. And thanks for listening, everyone. See you on the next episode.